Hi, everyone. Welcome to our November ICARE Case Conference. I'm Payal. I will get into the first case and then introduce our guest expert. So this is a patient that I've been following in my clinic. She originally tested at age 30, given there was breast cancer in her sister who had tested positive. The variant is the C823 Duke T variant. Age 31, she had a total body MRI finding, initially thought to be malignant peripheral nerve sheath tumor, excised and found to be a schwannoma. Again, I don't think that's associated with TP53, but I will ask, we can discuss that with our guest expert. Subsequently, she had risk-reducing mastectomy and was found to have DCIS on one side on path review. And you can see kind of her family history. Sister with breast cancer, mother with breast cancer, age 36, glioblastoma, age 62, and then breast cancer in the maternal lineage, both in the mom's mom and mom's grandmother. So she just coincidentally messaged me in the patient portal just a couple of weeks ago. So the bottom line here is she had a primary care doctor who was prescribing her metformin. She's now changed primary care doctors because her prior one had left his practice, taking 2 grams of metformin daily for the past year, no side effects. She was hoping her new PCP would feel comfortable, but the new PCP wanted her to reach out to me and to prescribe it. So she wanted me to give her a prescription. So my questions for our guest expert are, how do I advise this patient? We're already going to talk about evidence regarding metformin. Is it appropriate for someone like myself to provide her a prescription? Because anyone can really provide these patients with prescriptions. Would certainly refer her to an open clinical trial should there be an opportunity. Again, we'll talk about that as well. So again, I would love some advice on this. So with that, I will, I'm really excited to introduce our guest expert, who is Dr. Payal Khincha. So Dr. Khincha has an impressive background. She is currently a Lasker Clinical Research Scholar, Clinical Genetics Branch at the National Cancer Institute back in 2012. So she's had a long-standing interest in genetics, which is very apparent. She was in 2012, special volunteer clinical collaborator as part of research clinical fellowship in Peds Hemonc. 2014, she formally joined as a clinical fellow. 2017, became a staff physician. 2018, she took over as the PI of the longitudinal family study on Li-Fraumeni syndrome, which I will say I do refer patients to, and I would encourage others to do so as well. And more recently, she's working on a clinical trial that she's trying to get open, focused on metformin. So Dr. Khincha, thank you so much for being our guest expert. I'd love your feedback on the case, and then we can get started with your presentation.
Sounds good. Thank you so much for the opportunity. I'm really excited to be here among this audience and on a pivotal day where the US government is actually back open, which means we've got our folks back, we've got our teams back, we're going to be up and running with everything, even though some of us, including me, have been here all through the shutdown every day. So it's a great day to be talking science and to be talking patient care. I think going back to the case, this is one of those cases where my clinical hat and my scientific hat are sometimes at war with each other, and I can go through some of the evidence that we have and the plans for a clinical trial. But sometimes our trials and our science is really driven by the questions that are asked by patients. And so, this is one of those instances where, is metformin helping? What is it helping with? If I take it and it's not causing me any harm, can I just continue taking it? Who can I take it from? And I think metformin is one of those examples of where it's a medication that's not, at least, in the US, it's not hard to get. It can be prescribed by either primary care or specialist physicians. Side effect profile is generally not terrible. So, we sometimes think, okay, if it's helping you sleep better at night, and it's not causing you any issues, as long as you understand there may be interactions with other medications, and all medications have some sort of side effect profile, then okay. But on the scientific side, what is the evidence really behind metformin? Does it really do anything? We hope it does something. Does it do something for all cancers? Does it do something for some cancers? Is sort of the questions that we're going to try to get at with the clinical trial that we're developing. And so to answer sort of, really metformin is one that, like I said, this patient has had it from her primary care physician in the past, from an oncologist in the past. But it may be worth sort of discussing the evidence or lack thereof in humans, sort of some of the biology work that's behind it, and really talking about it comes down, I think, to a personal decision. From a scientific perspective, there's not a huge deal of evidence to say, yes, metformin either reduces or delays cancer incidence and progression in LFS, and that sort of, like I said, is what we're hoping to learn with the trial. So maybe I'll go through the presentation and then we can sort of come back to it after. All right, so like I said, thank you so much for having me. It's really exciting to be part of the webinar today. And so the way I think about inherited cancer, and this is not just for Li-Fraumeni syndrome, but you could apply this really to any cancer predisposition or to many rare diseases, is it's along a spectrum of understanding what the risks of the phenotypes and the etiology are, how can we detect the disease or the syndrome, how can we promote screening or early detection for cancer, and other medical issues that arise in many of these syndromes. For LFS, it's primarily cancer. What are the psychosocial, emotional, and financial impacts that this has on individuals and families, management, and then really those lead to sort of understanding how can we prevent these outcomes or cancers from happening. And then, of course, this leads to what is the population impact of having either LFS or germline P53. And so in my mind, these don't exist in silos, but are really informative to each other and really help drive the science and the evidence forward so we can take that clinical care back to the patients. And so LFS to this audience really does not need an introduction, so I'm going to try to be brief so we have ample time for discussion. It's an inherited cancer predisposition syndrome that has very high lifetime risks. We use it as sort of a prototype cancer predisposition when we talk about things like screening and prevention. Very high penetrance of having at least one primary cancer by age 70. There's also a very high risk of developing multiple primary cancers over the lifetime, which makes screening important through the lifetime. And the most frequent cancers are premenopausal breast, sarcomas of the soft tissue and bone, brain cancers, adrenal cancers, hematologic, among a host of other head-to-toe cancers. And germline pathogenic and likely pathogenic variants in the well-known TP53 gene are the only known genetic cause to date. And so some of the work that we've done so far has tried to refine some of these risks and patterns. Our recent study that we did and our team looked at our cohort of longitudinal LFS enrollees, and we had 480 individuals. And we showed for the first time that individuals with LFS have almost a 24 times higher incidence of any cancer than the general population, with that highest comparative incidence in early life. And the median age of cancer, which was consistent with a lot of other reports, was in the early 30s for females, mostly because of the very high risk of breast cancer, and mid 40s in males. But of course, as genetic testing has become more commonplace and has advanced, so has the phenotypic spectrum of LFS and what we now call heritable P53 related cancer syndromes is. And so this sort of nomenclature was proposed by the Li-Fraumeni Research Exploration Consortium a few years ago to think about, families that come into clinic that have the classic LFS pedigree where multiple generations of cancers. And then as genetic testing became available, having P53 germline variants associated. But also now what we're seeing even more commonplace is individuals who have had variants identified on clinical genetic testing, but may not have that classic pedigree or that classic family history that we've been used to learning about and seeing. And so how do we capture all of this spectrum of having a variant? What does that mean for phenotype? Or having a phenotype and not having the variant, and how that leads to clinical care. So now we call this the phenotypic spectrum of LFS or heritable P53 related cancer syndromes. And there's still work to be done to really understand what each of these mean. What does it mean to have a variant that may not have that classic presentation? And what does it mean to have the classic presentation but not have a P53 variant associated? And so with this sort of heterogeneity of cancers, with the risk starting in infancy all the way through adulthood and the variety of cancers that develop, obviously cancer screening for LFS is rigorous. It is head to toe. It is multimodal. And we have national, of course, the NCCN guidelines that Tua, of course, is co-chair of and know this very well, guidelines that help clinicians manage what is required or what is recommended for individuals with LFS, but also international guidelines from the AACR workshop a couple of years ago that was updated from the 2017 recommendations for not only pediatric but adult individuals with Li-Fraumeni syndrome as well. And so screening is really centered around, like I said, head-to-toe screening. Cancer screening is centered around annual whole body MRI in whatever way, shape, or form it is available, and annual brain MRI specifically done for the CNS cancers. Breast screening starts very early for females because of the risk, and the current guidelines are to start breast MRI at age 20 and mammography in females over 30 for females who have any breast tissue. And then, of course, like I said, it's multimodal. So there's physical and dermatological examinations, biochemical blood work, abdominal ultrasounds, upper and lower endoscopy every 2 to 5 years, and then importantly, discussing risk-reducing mastectomy in women as early as their late teens because of the risk of breast cancer. And then, of course, as Tua mentioned, newer to sort of the guidelines and recommendations are to consider prostate screening in males and consider pancreatic cancer screening. And there's some work going on to understand what this is going to mean and how well this works in the specific setting of LFS. But of course, there's a burden of cancer in cancer screening, which leads us to think about how can we prevent cancer? Because the cancer screening helps in early detection, but doesn't really prevent it from occurring. Depending on the study and the institution you look at, the asymptomatic cancer detection rate from screening is anywhere between 4 to 9%. There's a high false positive rate of any screening that adds to the burden of clinical follow-up. This is LFS screening is one of those rare situations where I say everything is guilty until it's proven innocent of being a cancer. And when you look at LFS as a cohort, the average annual cancer incidence is about 5% per year, which is pretty high. Of course, there are barriers to screening, notwithstanding just financial barriers, insurance coverage issues in the United States, being able to get it in areas where there may not be the centers available or the technologies available. There is significant psychosocial, emotional, and distress associated both with the cancer risk, but also with cancer screening. And there's physical or access barriers to being able to get screening. And so this really brings the case of, what we know cancer screening in its current state works at detecting cancer early, but can we now think about alternative cancer screening modalities that may complement and mitigate some of those burdens of cancer screening? And this is where the multi-cancer early detection techniques come in. And this is a focus of the Edison Consortium, of which I am one of the PIs. But I think Dr. Raymond Kim is scheduled to give the next case conference, and he'll have a lot of wonderful data to show on this in heritable cancers, including LFS that they're doing up in Canada. And so with that, we know screening detects cancer early. The question is, how can we work on preventing them? And P53 has a multitude of functions in the body. We call it the guardian of the genome. It's one of the most well-studied proteins and genes. For thinking about prevention, we decided to zero in on one of the functions, which is on oxidative stress or a mitochondrial metabolism, and really leverage what we know about metformin acting through both AMPK-dependent and independent pathways on mitochondrial metabolism. And this really builds upon over a decade's worth of work from our collaborators here at the National Heart, Lung, Blood Institute, who really took this upon themselves to understand in deeper detail and give us really a biological foundation of why we think this might work. And so studies over the years, I'm going to sort of condense it all into one slide, but this is a lot of wonderful work. Studies have shown that individuals with LFS have indeed increased oxidative phosphorylation compared to controls who don't have LFS. Mouse model work has shown that disrupting mitochondrial metabolism reverses some of the abnormal signaling and increases survival in LFS mouse models. Other studies have shown that metformin inhibits mitochondrial respiration in individuals with LFS and activates some of that anti-proliferation signaling that may help in preventing or delaying cancers. And then importantly, there was a mouse model study many years ago that showed that mice that had drinking water with metformin in at clinical levels had an increase in their cancer-free survival time. So sort of all of this evidence put together gave us a biological basis to say, okay, this is worth looking into a little bit further, and to understand that, mouse model and preclinical work may not always translate into human phenotypes and outcomes. And so we did a phase 1 trial of metformin and LFS here at the NCI, where we mimicked what we thought would be amenable to a clinical trial in the future. And so this was over 20 participants who came in, did a dose escalation of metformin to really understand the safety, the feasibility, the tolerability, and the effects on mitochondrial respiration. And so just a couple of the highlights of the results here. As expected, metformin is a medication that's been studied for decades, and we did not see any untoward or unexpected adverse events. Most of the adverse events that were recorded were GI adverse events that we know about. And indeed, in the individuals who were taking metformin, there was an inhibition of the mitochondrial function as measured by liver metabolism of metformin. And so with this, and taking that, it was feasible, it was tolerated, we spent a lot of time thinking about how to design a phase 2 clinical trial design, which is, we call it MILI for short. This is not an official name. We'll have to think about, sort of catchy acronyms, but metformin in Li-Fraumeni syndrome. And the idea was to create a randomized controlled trial, which would not be placebo controlled for different reasons. Look at the primary outcome of cancer incidence and look at the primary analysis endpoint of 5-year cancer-free survival. It's designed as a 2-year accrual and 5-year follow-up study, and we have power to detect 50% effect of metformin in cancer incidence reduction in 155 individuals per arm. So this trial would include individuals who have a confirmed PLP P53 variant, don't have any active cancer, and importantly, have not taken, are not currently on metformin or have not taken metformin for more than 6 months. And this is more so we can really understand what metformin does and not have it confounded by prior use. Where is it currently? We have scientific approval received. We're getting ready to go to the IRB, and funding God's willing, we should be ready to launch in the next few months if everything goes well with ethical review. But importantly, what this not only does this set a framework to do a clinical trial and really talk about this, whether metformin is the eureka drug that will help reduce or delay cancer occurrence in LFS, but it also provides the platform to really continue to advance multidisciplinary research and collaborative research in LFS. And so to take you through a little bit more of the details, so the primary objective of this trial will be to determine if individuals with germline variants taking metformin will have improved 5-year cancer-free survival compared with those who are not. We have a lot of secondary and exploratory objectives. One is to really identify and characterize and build upon the work that we're currently doing in cancer-related distress, but also, as I'll talk about in a moment, create an international consortial collaboration to understand in bigger populations the effect of metformin. And like I mentioned, exploratory objectives to really understand the mechanistics of metformin, to really understand where in that carcinogenic pathway metformin is affecting the development of tumors or delaying tumors, and also provide the framework for looking at alternative modalities of cancer screening. So this is just a very quick schema. Well, we'll have individuals who are screened and deemed eligible. They'll undergo cancer screening to make sure there's no prevalent cancer. If they are cancer-free, they will be randomized to either the control arm to get cancer screening only, or the intervention arm, which is screening and metformin, but we'll do dose escalation, as I mentioned, and the study after 5 years of follow-up. And just a very simple roadmap to see that they'll have annual cancer screening at the NCI. We will do interim blood collections to really build up repositories for further research, but also understand MSEDs and other alternative screening modalities as well. And like I mentioned, this has really been wonderful to see the international involvement and commitment of folks who are willing to look at this in different settings, but to really ask this question once, ask it right, ask it well. And so over the last 4 years, we've had wonderful collaboration and discussion with our international colleagues, specifically Sarah Gladwin in the UK, Deb Malkin in Canada, and Christian Kratz in Germany. We spent a lot of time coming up with a shared protocol that would be launched at each individual site with the same outcomes and the same framework, to then facilitate a planned meta-analysis at the end of the completion of these trials to be able to give us the power to look even further and deeper into smaller effect sizes. So where we are, we're going to IRB here at the NCI, and hopefully we'll be launching soon. The UK trial is actually commenced. The Germany trial has received funding, and we'll get updates soon on what their status is and when they plan to launch. And the Canadian site, which we were hoping would be our pediatric site, is well into the funding applications to get funding. So like I mentioned, this to me is not just the answering of, does metformin work, but it really helps advance research in LFS in many different ways. And some of those include really digging into biology of how cancer develops in LFS, why it develops, what are the pathways that we can also target. If metformin is working, but it's not working perfectly, then it provides us the opportunity to look into other targets and provide the framework on the trials to look at other drugs as well. Cancer screening and standardization of screening protocols will be really important, as well as looking at alternative screening strategies. And of course, really important is to understand and advance some of our work on the psychosocial and biobehavioral research as well. So with that, I'm hoping we'll have a great discussion. I have a lot of people to thank, mostly our patients and families without whom we can't do any of the work, our patient advocacy partners, and my many friends and colleagues and partners around the world. Thank you.
Thank you so much. That was fantastic.